Good afternoon again and welcome. We began our COVID-19 webinar series in March of 2020. And to be honest, we never thought that we would still be talking about the pandemic in 2022. But here we are, and there's still so much for us to learn about the novel coronavirus. This is the 33rd webinar in our COVID-19 webinar series. And responding to the high impact health issues is certainly core and central to the mission of Allergy and Asthma Network. You see our mission here, to end the needless death and suffering due to asthma, allergies, and related conditions through our 4 mission areas: outreach, education, advocacy, and research. So we are honored that you've chosen to spend some time with us this afternoon as we discuss COVID-19. We're also honored to introduce and welcome our speaker, Dr. Shahzad Mustafa, to our webinar. Dr. Mustafa completed his internal medicine training at the University of Colorado and stayed in Denver to complete his fellowship training in allergy and clinical immunology at the University of Colorado National Jewish Health and Children's Hospital of Denver. Dr. Mustafa is the Chief of Allergy, Immunology, and Rheumatology at Rochester Regional Health, where he sees both pediatric and adult patients. He is also on faculty at the University of Rochester, where he is Clinical Associate Professor of Medicine and the Clerkship Director for the Medical Student Elective in Allergy and Clinical Immunology. In addition to teaching and seeing patients, Dr. Mustafa is also a lead investigator on multiple clinical research projects. Dr. Mustafa, thank you again for being with us today, and we look forward to hearing from you in just a few moments.
Thanks so much.
Again, I'm Tonya Winders, the President and CEO of Allergy and Asthma Network and the President of Global Allergy Airways Patient Platform. And today I will host the program as we go throughout our 3 key topics. Here you can see that we first will talk about the current state of COVID-19. Secondly, we'll turn it over to Dr. Mustafa to talk about immunity issues. And then finally, we'll wrap up with management options for COVID-19. So as you all know, we love to get your feedback and interaction during these times. So let's go ahead and do our first poll. Which category best describes you? You can log in your response now: physician, physician assistant, nurse practitioner, nurse, school nurse, respiratory therapist, asthma educator, health educator, and patient and/or caregiver. So we'll give everybody just a moment to log in their response. We did have well over 600 people registered for our webinar today. It's amazing that 33 webinars in, we're still seeing such a great interest and response, and appreciate you all continuing to show up and engage in these educational and informational discussions. Just a minute longer. Looks like we've got a very diverse group on the line today, which we love to see. All right, I'm gonna close the poll and share. Looks like we have 6% doctors, physicians, 3% PA/NP, 56% nurse, school nurse, 25% RT, asthma educator, health educator, and 10% patients. You know, that's one of the unique things about the network, is that we always love to see that fully representative population and community on these webinars. And so I'm glad to hear and see that we're continuing to meet the needs of that diverse community. So let's take a look at the current state of COVID-19 as of today, January 20th, 2022. You can see here by the COVID-19 dashboard at Johns Hopkins University that we have now exceeded 338 million total cases. Again, that 28-day case rate at over 60 million. The total deaths now exceeding 5.5 I'm sorry, billion. I don't know what I said. Yeah, so I moved my decimal. I must need coffee here this afternoon. Nonetheless, so we're seeing those case rates continue in the red across the world. But we know that this Omicron variant has really had a significant impact in the last 28 days as we look across the world. And yet we still see some regions of the world where there are very few cases. When we dig in a little bit deeper on the CDC data, here you can see the total case rate for the US, as well as the new cases nearing 1 million there, and the 7-day case rate per 100,000. Again, unfortunately, this data does lag just a little bit. The Johns Hopkins data is a little bit more timely, but what we tend to see again are these variances in various pockets across the country. So the darker the blue, the more intense the case rate per 100,000. So the Carolinas are definitely getting impacted significantly. And we still see a lot of high case rates across the Deep South as well as the West. So what about in the news? What are the headlines telling us this week, as in this month, as we gather? Of course, as I mentioned, the case rates of COVID-19 really have been on the rise, specifically because of the Omicron variant. But thankfully, hospitalization numbers have been relatively low. So for those vaccinated individuals, evidence suggests that infection with this particular variant seemed a little less severe. And in fact, epidemiologist and former Detroit Health Department executive, Dr. Abdul Ayad, has commented about the fact that this particular strain does seem less significant and severe for most patients. The U.S. Food and Drug Administration has formally authorized Pfizer's COVID-19 vaccine booster for adolescents 12 to 15. And boosters are now available for everyone 12 and older here in the U.S. So that's very encouraging now that, again, our students, teenagers, young adults can all be vaccinated as well. As we continue to look at the headlines, a few other key points to point out. There have been some additional changes in the CDC recommendations. It seems like that is a common theme every month when we gather here. But people with COVID-19 should isolate now for 5 days, even if asymptomatic or if symptoms are resolving. And they should then follow with 5 days of wearing a mask around others. So this particular change was motivated by some of the science that demonstrated the majority of the transmission of SARS-CoV-2 actually occurs early in the illness. And so that's why this change in the recommendation of those first 5 days, even if asymptomatic, isolating and waiting until symptoms resolve, and then 5 days of mask wearing thereafter. So if you were exposed to someone with COVID-19, how should you quarantine, or should you quarantine? Again, if you have been boosted or if you've completed that primary series of vaccine in the last 6 months, if Pfizer and Moderna, or 2 months with J&J. And so again, you can see here the treatment algorithm, the recommended activity of wear a mask around others for 10 days, test on day 5 if possible, and stay home. If you, on the other hand, had completed the primary series of the Pfizer or Moderna vaccine over 6 months ago, or are not boosted, or if it's been longer than 2 months on the J&J, or if you're completely unvaccinated, then it goes to that recommendation of staying home for 5 days, wearing a mask after that for an additional 5 days. And if you can't quarantine, it's very important to wear your mask for up to 10 days. And definitely around day 5 is that period where the recommendation for testing is. So the US has now surpassed its record for COVID-19 hospitalizations last Tuesday. And again, we really don't have this end in sight for these skyrocketing caseloads. And I know that you all on the front lines know this better than anyone. We currently have over 145,000 patients in US hospitals, specifically for the diagnosis of COVID-19. And I think about the quarter of our attendees today who are respiratory therapists, asthma educators. And once again, my heart goes out to you, because for over now 2 years, you have continued to navigate these most challenging days in the hospital. And we appreciate that service on the front line and all that you all are continuing to do in the face of the pandemic. Now, under the new policy announced by the White House, individuals that are covered by a health insurance plan who purchase an over-the-counter COVID-19 diagnostic test that's not been authorized will be able to have their test covered by insurance. Also, there was a new development yesterday where every household or 2 days ago, where every household can receive 4 at-home COVID tests for free. And we do have that website where you can obtain those we'll drop that into the chat and also share it with you all in the after notes for this webinar today. But every household in the US is now entitled to 4 free at-home COVID test kits. So these are our COVID cases by day. And so again, you can see the way that this has trended over really the last, since the beginning of the pandemic, and the way that we've continued to trend on a per date rate over the last year. Let's see, actually, sorry, this is the last 2 years time frame. It's so stretched out. You don't see those changes as evidently as when we compress and look at more distinctive timelines. But what you do see again is that unfortunately we've had such a high uptick of new cases by day with this Omicron variant. Definitely a much more virulent strain than what we've seen with Delta. So there is significant risk for severe disease among hospitalized adults with asthma or COPD. And hospitalization among patients with asthma and or COPD with COVID actually had a more severe clinical course than hospitalizations for asthma and COPD without COVID. And so this is some data that actually takes a look at ICU admissions for patients with asthma and COVID, invasive mechanical ventilation for patients with asthma and COVID, and death for those patients with asthma and COVID. So again, compared to that ICU admission for patients without asthma, we see a statistically significant difference of 46.9% versus the 1.17%. On the invasive mechanical ventilation, 14% versus 1.61%. And then on the death toll, patients with asthma and COVID, 8%, patients with asthma but not COVID infected, 5.56%. So again, you see that increased risk for severe disease among those adults with asthma and or COPD and COVID. So now let's go to our second polling question of the day. Have you witnessed the surge of COVID-19 in your own community in the most recent 30 days? Yes, no, I'm not sure, or we don't really seem to be having a surge. There are those few pockets across the country. I know in our own staff at Allergy and Asthma Network, the first week back from the holidays, we had a couple of people out. The second week back, we had 3 people out, and the third week back, we had 1 person out. So it's definitely been running rampant even through our small organization, and even though we are remotely located throughout many different states of the US. So we'll give it just a minute longer. Looks like we've got about 3/4 of the response rate here. And then I'll share the results. So it looks like 94% overwhelmingly you are seeing that surge of COVID-19 in your community. 1% say no, 1% say not really having that surge, and then 4% not sure. So again, unfortunately, we are seeing this particular strain being much, spreading much faster and impacting many more individuals. However, it does seem to be less severe symptoms, and the recovery seems to be a bit quicker and better. And the symptoms actually quite different than the original variant of COVID-19. So it's really fascinating to see how this strain has presented so differently among our community. So now I'm going to turn it over to Dr. Mustafa, and he is going to give us an overview of immunity issues. Dr. Mustafa?
Thanks so much, Tonya. Thanks for that great overview. And certainly, there's a whole lot of COVID in the community right now. And a lot of us, younger population, generally healthy individuals can protect ourselves with vaccination. But individuals who have glitches in their immune system, immune defects, potentially remain at risk. And that's what we're going to focus about, who they are and some potential ways to treat them and others. So real quickly, there's multiple components of the immune system. It's very complicated, much more than I understand. There's these little proteins called complement proteins that are very early to react, neutrophils and phagocytes. T cells are important. They really help with viral infections. COVID-19 is certainly a viral infection. And one of the biggest components of the immune system that we understand really well is antibodies. And we've heard a lot about that on TV, about antibody levels after vaccine, all that stuff. So we're going to spend a little bit of time focusing on antibodies and a little bit T cells, which are the predominant parts of the immune system that we kind of understand best and can measure. So there are a lot of causes of immunodeficiency. It's super broad. Newborns are immunodeficient. Their immune system hasn't developed yet. As we age, we get into our 80s and 90s, our immune system can lose a little bit of responsiveness. So there's a lot of things that can make us immune deficient. The big ones I'm going to focus on are on individuals with blood cancers, individuals with lymphoma and myeloma and CLL, chronic lymphocytic leukemia, and many medications can make us immune deficient. If we're on steroids, oral steroids, prednisone for long periods of time, that can make you immune deficient. Not short courses for 5 days or a week, but long, prolonged chronic use. And then there's a lot of chemo agents. One that I think people may have heard of is rituximab, which is an anti-B cell. B cells make antibodies. So there are medications and conditions that we will focus on that really do lead to significant immune defects. So this is a super old study, and the only reason I show this is because I want to show you that we've known for over 50 years. This study was published in 1973. Actually, I feel old. This was even before I was born. That individuals with MM, that's multiple myeloma, or CLL, chronic lymphocytic leukemia, compared to individuals with MI, which is heart attack, coronary artery disease, their risk of infection is way higher. In fact, infection is the #1 reason people with blood cancers die. They don't actually die of their cancer usually, they die of infectious complications. And that is the point of this slide. This is old news, we've known this. Medications can do it too. This was just published from a friend of mine, Dr. Walters down in Florida, of individuals who are being treated with rituximab. Rituximab is a medication that treats lots of conditions, including blood cancers, rheumatologic illnesses like rheumatoid arthritis and lupus. And what we know is rituximab wipes out bad antibodies, antibodies that are causing ruckus, and that's good. But guess what else it does? It wipes out good antibodies. So when you get treated with rituximab, your antibody levels go down. Your risk for infection goes up. So again, trying to just kind of frame the conversation around there are health conditions that cause it, there's medications that cause it, and here's a double whammy. Some of these medications that cause immune defects are used to treat the health conditions such as blood cancer. So rituximab is routinely used to treat lymphoma. Now you have kind of 2 hits against you. So what do we do right now? So if infections are a big problem, I said they're the #1 cause of death from blood cancer. We know the infection that's the biggest problem is pneumonia, and we actually know the bug. It's strep pneumo. So what do we do to protect these individuals? We vaccinate them, and everyone should be vaccinated who have these conditions with Pneumovax or Prevnar. But guess what? Despite our best efforts, infection remains the #1 cause of complications and death from these conditions. This is what we're doing right now. These are guideline-based practices. So why are we failing? This is why we're failing, vaccination and immune deficiency. So vaccines build antibodies. I think we all know this now over the course of the last 2 years. What makes antibodies? B cells in our immune system make antibodies. So what happens with B cells? B cells, oh, there's a typo, I apologize. B cells are abnormal in individuals with blood cancer like lymphoma and leukemia. And then you use medications like rituximab or ibrutinib that further deplete B cells. So individuals who have these conditions have abnormal B cells, and we rely on B cells to make antibodies to vaccine. So what happens is these individuals, even though they're being vaccinated, are not mounting adequate antibodies. And that is the underlying problem that leaves them at risk. So what does that actually mean? Let's look at that. So there's on the top left, there's a bunch of conditions. The very left is normal control. So 99% of individuals who are vaccinated with 2 doses, this is important, this study was done with 2 doses of mRNA vaccine, 99% will demonstrate antibodies to COVID. That's what we expect. And there's these other conditions, lymphoma and leukemia and multiple myeloma and CLL, chronic lymphocytic leukemia. Look at that on the far right. When individuals with CLL get 2 doses of mRNA vaccine, only 47% in this study demonstrated antibodies. So about half respond with antibodies and half don't at all. Lymphoma is a little better, 60 to 70%. Myeloma is about 76%. But again, a significant amount of individuals aren't really building antibodies despite 2 doses of mRNA vaccine. The bottom graph shows that even the ones that do respond, the 47% or the 60%, the levels that they respond to are much lower than normal controls. So the point here is, and then the right graph just says that CLL is definitely the worst of the 3 between lymphoma and multiple myeloma. So the point here is individuals with these blood cancers often do not respond to vaccination, and even when they do, it's a suboptimal response compared to normal controls and their peer group. This is just another slide from the kind of a similar study about vaccination. So of course, on the left, it shows if you're not on treatment for your cancer, it's milder, it's early, you're watching and waiting, your likelihood of responding is better than if you're on therapy. And we mentioned why that may be. Many of the therapies further immune suppress, further deplete B cells, and it doesn't really matter which therapy. So the point of this slide is, when you're treating blood cancers, many of the treatments are the second hit, so they make their immune response even more. They're immunosuppressive. And I just wanted to give one more study on rituximab. So roughly a third of individuals, this is in rheumatology patients. I just wanted to add this, but it's not just cancer patients. These are patients with lupus, rheumatoid arthritis, other vasculitises. About a third of individuals who are on rituximab respond with detectable antibodies after 2 doses of vaccine. The best predictor of who may not respond is your antibody levels, which we talked about earlier. Your antibodies, rituximab makes them lower. So again, we have health conditions that are causing ruckus. We have medications that we routinely use that are causing ruckus. And in some individuals, we have both. So, there's a lot of talk with the CDC and recommendations, and we're going to talk about these treatments that are for immunocompromised. So I want to talk about that. That's really broad. We started with that, right? Clearly, with people with blood cancers are immunocompromised. Clearly, individuals on certain chemotherapies and treatment regimens are immunocompromised. Individuals with rituximab or B-cell depleting agents. We use these in neurology sometimes with multiple sclerosis. We use it in nephrology sometimes with really bad kidney disease. This is a study that looks at individuals with a bunch of inflammatory conditions like Crohn's disease, ulcerative colitis, certain types of arthritis. And these individuals on the left, this is individuals normal hosts with no health conditions versus individuals with chronic inflammatory conditions. What you see is the immune response to COVID vaccination, it's similar. It's actually not that different. This is reassuring. Many of us are familiar with TNF inhibitors, which is the middle graph here. Medications like Remicade and Humira and Stelara. We see commercials all the time for psoriasis and Crohn's disease and other inflammatory conditions. TNF inhibitors do have immunosuppressive qualities, but in this study, people on TNF inhibitors mounted adequate response to vaccine compared to individuals not on TNF inhibitors. So again, very reassuring. My sister has Crohn's disease and is on Remicade. I worry about her all the time. But she should have mounted a pretty decent response to her 3 COVID vaccines, which I would show with this study. And interestingly, on the right, the numbers are smaller here, but one of the biggest predictors of a poor response was actually prednisone, a medicine we all use frequently. Not a short course, not alarming. If you get prednisone for poison ivy or croup or a little asthma for 5 days, you're going to be okay. But chronic prolonged prednisone use absolutely decrease your response to COVID vaccination. So those studies I showed you were all with 2 doses. So where did this whole 3rd dose come? And heck, now we're floating around an idea of a 4th dose. We can talk about that. This was very early, and this came from solid organ transplant. What this slide shows you is individuals who had solid organ transplant are on chronic immunosuppression so they don't reject their organ. After 2 doses, many did not respond to vaccination by making antibodies. So in these individuals, a 3rd dose produced detectable antibodies in about a quarter of individuals. So the bottom line is 2 doses was suboptimal in many individuals with immune compromise on immunosuppression, but a 3rd dose got about a quarter of them home. So 3 doses better than 2. very little downside, no real side effects. So well tolerated and maybe, not for sure, but maybe effective in individuals on immunocompromised. So that is where the first recommendations of a third dose, a booster dose for vaccination came from. This has since been studied in other conditions. Let's go back to CLL. We said that, right? These are some of the poorest responders to vaccination. 46% were responding to 2 doses. Same thing, guys. If you gave them a third dose, about another half, so another quarter, responded and made antibodies. And you see on that right, those are individual patients. You see some patients with big, like, sloping lines going up. That's good. That's a nice antibody response. It wasn't there with dose 2, but it was there with dose 3. Again, are there things we can do to predict who is going to respond and who's not? Lack of therapy is a good sign. If you're not on active chemo, that helps your cause. Your antibody levels, the bottom line there in that graph, serum IgA is an antibody level. If your antibody levels are normal, you tend to do better. But again, this is where the recommendation came from originally for immunocompromised individuals, that a third dose may build antibodies much more so than a second dose. Now, we all know since these studies that this has now been extended to a broader population. And this is, again, the same concept. 3 doses are going to crank up on your antibodies higher and hopefully will induce more long-lasting memory. So these are ways that we're trying to protect individuals, right? Vaccination remains the most important. We know that. And 3 doses is better than 2. We do know that. Every individual who's eligible for 3 doses of mRNA vaccine should get it, particularly our immunocompromised individuals. And I'm being overly simplistic. We go back to those 4 boxes I showed you of the immune system. We're just talking about antibodies. There's other parts of your immune system that respond to vaccines. T cells respond to vaccines. And even if individuals don't mount high antibodies or good antibodies, they have probably other immune responses to the vaccination. So I don't want us to think of vaccination of it works or it doesn't. It's not binary. There's degrees of how well it works, right? So I will say for sure in these populations that I take care of, their vaccine response is suboptimal, but it's not 0. So again, they get something, some get more than others, but it's not 0. So very, very important to continue with vaccination. So we have individuals with immune compromise who are on immune globulin replacement. So these are individuals who are getting chronic antibody infusions from blood donors. And what the point here is, this is coming from blood donors, so individuals in the community. So over time, these individuals who are giving blood, we're collecting plasma and then commercializing it and then infusing their antibodies into individuals. On the bottom, you see we have detectable antibodies in immune globulin. So for individuals who are on immune globulin replacement or physicians who prescribe immune globulin, we should be telling our patients that most of the products today do have some level of detectable COVID antibodies. So that's a way to get antibodies to individuals who may not be making them. Now, it's hard to know from the time someone donates blood to the time it gets into someone's arm, about a delay of 9 to 12 months. So I have some patients who are getting products from still 2 years ago, so those won't have COVID antibodies. But the point here is, as our immunity grows in the community, either through vaccination or natural infection, we will be passing along some of these antibodies in our immune globulin products. Do not take away that Dr. Mustafa is saying to start immune globulin replacement to have be protected from COVID. That's not the case. I'm just saying for individuals who are already on this therapy, they may be getting some protection from this as well. So we vaccinated people. If they're on immune globulin, they may get it there. What other ways are there to provide antibodies to people who may not be making them? There's this fantastic new medication. This is a little bit outdated. This stuff changes so fast. It's called Evusheld, Evusheld. This is actually an antibody that's synthesized against COVID. It's not a human product. It's synthesized. It has been messed with where most antibodies go away in about a month or so. This one will actually last 6 to 12 months. So Evusheld has become emergency use authorized to administer to individuals who are at high risk of not mounting adequate responses to the vaccine, COVID vaccine. So they are being vaccinated, they're not mounting a response because of their cancer or their chemotherapy. We're just gonna give them the antibody. It's like giving a diabetic insulin. They're not making it, so we're just gonna give it. So Evusheld is 2 injections given at the same time. And then it provides these high-risk individuals with antibodies that last at least 6 months, maybe longer. Super exciting. In studies that included 7,500 people, there was a study with 5,000 people, a study with 2,500 people, individuals who had Evusheld had a significantly lower risk of acquiring COVID as compared to individuals who were on placebo. You guys remember seeing those graphs from the Moderna and Pfizer vaccine studies, how those lines separated? Evusheld has a very, very similar graph. So very, very exciting. It just became available the last couple of weeks. We just started giving it at our health center at Rochester Regional Health last week. We started with our highest risk individuals. These are individuals with CLL on therapy, individuals who are getting rituximab, and individuals who've had organ transplant on immunosuppression, heart transplant, lung transplant. Very, very exciting to be protecting some of these most vulnerable individuals. So this is Evusheld. Oh geez, so we vaccinated you. Maybe you're on immune globulin. Maybe you've gotten Evusheld and still you get COVID. So those are ways to try to prevent COVID. Now you have COVID. And so there are monoclonal antibodies to treat active COVID infection. If you watch the news, there's been some products. The one that's gotten the most press is the product they call the Regeneron. This is a casirivimab and nivolumab made by Regeneron. We've used product bamlanivimab and etesevimab by Eli Lilly. Unfortunately, those two products are not being currently used because guess what? We used them for about a year, including during Delta. They don't friggin' work against Omicron. What a punch in the gut. So right now we're using a product called sotrivimab, but these are all very, very similar. What these do is these are also injecting, it's an infusion. These are also injecting an individual for antibodies, but these aren't COVID antibodies. These are antibodies to neutralize COVID spike protein. So they kind of swarm up COVID spike protein so it can't attach to our cells. So again, this is not preventing infection. This is now treating infection. Very, very, very different. So what does it do? What do these monoclonal antibodies do? They decrease your viral load sooner. That's great. They make you feel better faster. Cool. But the real reason we do it, they significantly decrease your risk of progressing to severe COVID, to getting COVID pneumonia, to being hypoxic with low blood oxygen levels and being hospitalized. That's the reason we do them. I love that people feel better faster, but the goal is to keep them from getting really sick and hospitalized. And the beauty is they're fantastically well tolerated. Their side effects are really no different than placebo. So very, very exciting therapy. I should have mentioned this sooner. I can mention it at the end. It's going to be true for all the therapies that I talk about. Unfortunately, they're all in super limited drug supply. Evusheld is very limited. These monoclonal antibodies are very, very limited, and the oral antivirals that I'm going to talk about in a second are also very limited. So the drug supply is low. Demand is obviously high, as Tonya talked about, the numbers of infection. So even if we're just talking about immune compromised individuals, individuals at high risk, even small percentages of really big numbers is a pretty big number. So we are definitely battling a shortage of these wonderfully effective drugs. And then the third line of defense, you failed your prophylaxis, you got COVID after all, you didn't get sotrivimab, which is a monoclonal antibody. There are two oral antivirals, okay? Paxlovid, which is, I'm not gonna even try to pronounce the name, and molnupiravir. These are two oral antivirals, all right? I think the biggest thing to consider here is Paxlovid has significant drug-drug interactions, including drugs that many individuals are on, myself, with cholesterol medicines, Lipitor, things like that. The second oral antiviral, not quite as effective as Paxlovid. So if you have a choice, go for Paxlovid. But again, shortage of drug supply. The second one is contraindicated in pregnancy or in anyone who gets pregnant. So you really want to be careful about using that in women of childbearing age. Again, this, as well as the monoclonal antibodies, are not for prophylaxis. This is treating active infection. And you want to treat active infection early. For the monoclonal antibodies, it's within 10 days of symptoms. For the anti-oral virals, it's actually within 5 days. You want to treat them early as an outpatient to prevent progression to disease, to severe disease and hospitalization and actually death. So again, very, very exciting therapeutic options. in limited supply, but a big advancement in our treatment of outpatient COVID before people get sick and get hospitalized, because that's really the goal, to keep them out of the hospital. What is on my next slide here? So my summary. So I'd say, and we left a lot of time for questions, which I like, because there tends to be a decent amount of questions. I'd say roughly 3% of the population has significant immune deficiency, not the soft stuff. You know, technically individuals with diabetes have some degree of immune deficiency, but not really significant. I'd say 3% of the population, and we've talked about what that means. Those are people, anyone who's had an organ transplant is on immunosuppression, anyone with a blood cancer, anyone on significant chemotherapy agents. Certainly the most common one that we use in the US is probably rituximab. This is actually, they deplete your antibodies, good antibodies and bad antibodies. So certainly this is a significant population. By no means I'm saying vaccines aren't recommended. Vaccines are 100% recommended. I manage these individuals on a regular basis, and I certainly recommend 3 vaccinations for every single one of them. Even if their antibody response is suboptimal, they're probably having T-cell responses. But again, suboptimal does not mean 0. So they're getting something, maybe not as much as we want, but they're getting something. So for that reason, and this goes beyond COVID, this is for pneumonia too. We started with, goes back years and years, right? Vaccines are not protecting these individuals, and they remain at risk for infectious complications. Pneumonia remains the #1 cause of death in individuals with blood cancer. COVID remains very high risk in individuals with blood cancer, even if they're vaccinated. So because of this, it's very exciting to finally have some additional therapies, some additional management options for these individuals. Immune globulin may have COVID antibodies that we can talk about, additional vaccine doses. Evusheld is super exciting, and very thankful that it is active and does have activity against Omicron. And then if you do get sick, monoclonal antibodies and oral antivirals. I want to touch upon 2 points here that I didn't have slides on that I should have. Shame on me. You guys have heard of maybe remdesivir. Remdesivir is an IV infusion of an antiviral. It was used in the hospital to treat individuals who are sick with COVID. There is also data that remdesivir used very early as an outpatient can prevent progression to severe COVID and hospitalization. So that's also very exciting, because remdesivir actually is FDA approved, so there's no shortage of medication. The trick there is it's 3 consecutive days of infusions. So that's logistically pretty difficult to pull off. Our health system is actually working right now to operationalize using remdesivir to prevent progression of COVID. And I'm going to take this moment to talk about what question I get a lot. Should I get a 4th dose of a vaccine if I'm immune compromised? So I'm apolitical. I try to be a scientist and a physician, but I will take a shot here. So the CDC has vaguely, I think it's on purpose, vaguely recommended consideration of a 4th dose of mRNA vaccine in individuals with moderate to severe immune compromise. They didn't really define what moderate to severe immune compromise means. I hope after today's talk, we have a better sense of what it means. They left it pretty vague, and I think it's on purpose. And they recommended a 4th dose. I can tell you for a fact, as of late last night, there is not a single study on planet Earth that says a 4th dose of vaccine in any population decreases your risk of contracting COVID as compared to a 3rd dose. So what the CDC has done, they've made a recommendation despite the lack of scientific data. I'm not saying they're wrong, they may be right, we just don't have any proof that they're right. I always get a lot of anxiety making recommendations in the absence of good, well-done studies. So where are they doing this? They're really the first place they rolled out a 4th dose in high-risk individuals, and they defined it as individuals over, I think, 60 or 65 years of age, was Israel. And what's coming back? The very early returns, not on well-done studies, show that if you get 4 doses of vaccine rather than 3, your antibody levels against COVID go higher. But your risk of getting COVID doesn't go down. So those are the very, very, very preliminary returns from Israel that say a 4th dose may make your lab value look a little better, but it probably doesn't help you in the real world. That's not a study, that's just early returns. But as of today, there is no science to support getting a 4th dose, although that may be the CDC recommendation. And this is, again, near and dear to my heart. My sister has lots of chronic medical problems. She's had 3 doses. I have not rushed out to get her 4th. I manage lots of individuals with blood cancers and on immune suppressants. I've told them if they feel better getting a 4th dose, go for it, but they don't need to rush out and get one. As soon as we have good data, I would make a stronger recommendation. But for now, I think 3 doses is probably good enough. And there is a downside. I do want to speak to this. There's this concept of immune senescence. That means your immune system kind of gets bored if it sees the same stimulus over and over and over and over again. So I'm not saying anyone's recommending 8 doses of vaccine or 10, but if we were to do that, our response to each dose would probably go down, law of diminishing returns. So I don't think there's any real issue with getting a 4th dose. It may not be helpful in my opinion, but it's probably not a huge issue. But that doesn't mean you just keep banging on the immune system with more and more doses of vaccine, because you probably will induce immune senescence. There is a downside. Every yin has a yang, right? Everything we do in this life has a counterbalance. So that's where the 4th dose stands. Lots of people ask me about it. It is a vague recommendation, not totally rooted in good science right now. I think that's my last slide. It is, and I think we kind of hit our target for Q&A. So I look forward to it. I hope people learned something, took something away, and found this helpful.
Yeah, absolutely. Thank you so much, Dr. Mustafa. I learned several things and really appreciate the way that you, the simplicity with which you presented that data for those that are living with immunocompromised conditions. And so as we go to the questions, there are a number of questions. Let's just dive into some of those here. Feel free to go ahead and put your questions into the control panel. We'll get to as many as possible. And also want to remind you that we did enter into the chat where you can obtain those free COVID tests at your home. So the first question comes from Bruce and Zafira, who says 6 months after a person has a Pfizer booster shot, what is recommended for one living with severe asthma? So I think this speaks somewhat what you just spoke about on that 4th booster consideration. But why don't you go ahead and address Bruce and Zafira's concern?
Yeah, I think at this point, the recommendation is 3 doses of mRNA vaccine, or if you have a J&J to start with, a dose of an mRNA vaccine, and you're considered fully vaccinated. At this point, like I said, I don't think there's any real reason to rush out and get a 4th dose even 6 months after that 3rd dose. And at this point, yeah, I think 3rd doses were kind of rolled out late summer, early fall, right, Tonya? So we might be getting at that 6-month point. I'm going to take it a step further. Asthma obviously is a very, very heterogeneous condition. There is nothing in common between exercise-induced asthma versus an asthmatic who's been, hospitalized, for, God forbid, on a ventilator. But generally speaking, I would not consider moderate to severe asthma as an immunocompromising condition. Now, of course, if you're on high-dose steroids or something, you might be, but the asthma biologics that you might be on are not immunosuppressive. So I guess to answer your question straightforward, I don't think a 4th dose is indicated at this time, but as Tonya said, as some of these slides were outdated, even though they were made just a week or so ago, things are moving quickly, so we got to stay up with it. If it changes, we can change our recs, but that's where I think it stands today.
Absolutely, and I think that we also stay the course on all of the good infection control measures that we know work. And so, yes, Omicron is more transmissible. Yes, it is less as far as severe of symptoms. But what I'm understanding is it stays in the nasopharynx region for much longer and is much, even in asymptomatic people, much more transmissible. So it's important that, especially if you're out and about, Bruce and Zafira, that you stay very attuned to those good infectious control measures of hand washing, social distancing, and wearing a mask. So next, Dr. Mustafa, the question comes from Dina, who says, at what point is dexamethasone usually given to COVID patients?
Yeah, that's a great question. I didn't focus on that because that's primarily inpatient management of COVID. Systemic steroids, dexamethasone, are indicated once you have COVID pneumonia and you need oxygen, a low oxygen level. There's, I guess, 2 very basic phases of COVID infection. The first phase is the virus itself. And so you want to clear the virus, and some of these medications help you clear the virus. If you're vaccinated, you do a better job of clearing the virus. Then the second phase is your own inflammatory response to the virus. You're not having more virus. Now the virus is there. Now you're responding to the virus. And that inflammatory response is actually what causes a lot of trouble. So dexamethasone is used to cut down on that inflammatory response. So generally speaking, if we're going to follow good science, dexamethasone should be used when you're having COVID pneumonia or hypoxia and likely being admitted to the hospital. Now, I know individuals and physicians and providers are prescribing dexamethasone to individuals with outpatient COVID, but that's not really what the science would support. But so that is where it falls in the treatment paradigm.
Thank you. So a next question comes from a patient who's saying that they are experiencing inflamed and painful sensitive lymph nodes even up to a month after receiving their booster. Why might that occur? And is there anything they can do about it?
Yeah, so that's a hard question. There's lots of reasons to have inflamed lymph nodes. Absolutely, vaccination can do that. Vaccines are generally well tolerated. They're not perfect, but they're generally well tolerated, with side effects being pretty minimal and generally within 24 to 48 hours as your body mounts that immune response. We have seen, allergists have been doing vaccinology since the beginning of time. No one really cared until COVID vaccine rolled around, but we've seen a lot of individuals over the last year who have concerns about vaccine allergy or side effects. It's hard to know exactly what to blame that on. I would certainly bring it up with your provider, your primary care provider. Maybe you warrant some basic lab works. We talk a lot about inflammation. You know what? We don't really have to guess at inflammation. We have really basic labs that can tell us if we have inflammation or not. So if you have those concerns, I encourage you to reach out to your provider. There's other causes of lymph nodes being enlarged, viral infection, viral exposure. In fact, once your lymph nodes react to any virus, potentially, I guess, a vaccine, they can actually stay enlarged for 4 to 6 weeks. That's not uncommon. So maybe you're still in that window and coming out of it, but hopefully we realize the benefits of your vaccination still outweigh the downside, I hope.
Yeah, absolutely. And you made such a good point, Dr. Mustafa. Again, we have to continue to remind people that vaccination is not necessarily going to keep you from getting COVID, but absolutely the aim is to keep you from having severe symptoms and ending up in the hospital or ventilated and, God forbid, dying from COVID. And so when we have these conversations, it's really important that we talk about how we define vaccine effectiveness, right? Because as people get confused, that means, oh, well, I can't get the virus, or because I got the virus, the vaccine.
Yeah, Tonya, I think that may be one of the most important points in this whole hour, certainly more important than anything I said. I honestly think that messaging has been kind of botched by everyone. Vaccines often, particularly the COVID vaccine, it's not meant to keep you from getting a mild respiratory outpatient viral illness. It is meant to keep you from getting sick. And the messaging has been lost. So now people tell me, well, why should I get a vaccine? I can still get COVID. Absolutely. The goal is keeping you from getting sick. And for that, the vaccines are fantastically effective. I'm going to take it one step further. And I don't mean to offend anyone, because I'm all for personal choices and freedoms, and we all have them, and that's the beauty of this country. But I do think when it comes to vaccines and public health, especially in the middle of a pandemic, our personal choices have huge public health implications. One of the biggest reasons I got my children vaccinated, sure, I do worry about them getting COVID or some uncommon side effect. But one of the biggest reasons is it helps protect the community. It helps protect my immune compromised sister, or my older parents, or the cancer patient that passed at the grocery store. So there's a huge public health benefit to vaccination too. The concept of cocooning our most vulnerable individuals, herd immunity, protecting around them, has been around for hundreds of years. And I certainly believe in personal choice and freedoms, but they come with societal responsibilities, and a global pandemic is certainly a unique place. So I would encourage individuals who say, if I get COVID, it's no big deal for me. That is true for many people, thankfully. But you're still being vaccinated is so important for the greater good, for the individuals who may be vaccinated, who can't respond to the vaccine like we talked about, or other health conditions.
Yeah, that was perfectly said, and absolutely aligned with the position that Allergy Now Network has taken over these last 2 years. Now, our next question comes from Mark, and he says that many patients are actually complaining with severe headache and back and leg pain with the Omicron strain. It's often pointed to kind of that immune system response, and perhaps it's working. Do you think that that's the case?
Yeah, so again, there's two phases of illness, regardless of this degree. The first one is the actual viral infection, the viral load, and then the second one is the body's immune response to it. So yeah, absolutely. I think that maybe your immune response, fever, is a very, very protective response. It actually helps kill pathogens, right? Makes it feel like crud, but it helps kill pathogens. So that may absolutely be the cause. I also think it's very important to note that Omicron, it's still very, of course, it can be severe and huge numbers, small percentage, like I said earlier, are big numbers, but it does appear to be significantly different than Delta, which was a predominantly lower airway illness. Omicron tends to be an upper airway illness. Now, of course, there's special populations that remain at risk, but it does appear to be a little bit different. It's presenting a little bit different. And then even if we talk about these infections and breakthrough infections. If you get the virus after being vaccinated, it tends to present very differently than if you get the virus if you're unvaccinated. So again, very, very different in different populations and different circumstances, but Omicron does appear to be different. Yes, I agree.
Yeah. So Lisa has a good question. She says she's had all 3 of her vaccinations, but she's still wondering if there's a way to tell if she has the antibodies. She has asthma, knows what it's like not to be able to breathe, and even what a small respiratory virus or cold can do. So she's still a little worried about the risk of COVID. Is there any way to know if her antibodies are at an acceptable level?
Yeah, great question. So as an immunologist, I measure antibody levels for a living. I've been doing that since my whole career. Unfortunately, our knowledge of COVID, we still haven't gotten to a point where we know what level of antibody is protective or not. I'll give you an example. For pneumonia, for serotypes of pneumonia, 1.3 micrograms is protective. So whether your level is 10, 20, or 40, I kind of look at it the same. I mean, but intuitively, you think 40 is better than 20 is better than 10, right? But not for pneumonia or tetanus or diphtheria, not really. So for COVID, we don't know those cutoffs. So there are commercially available tests to measure your antibodies. There are, but it's hard to interpret the level. Some levels are, in the scale they're using. Some say 1,000, some say 60. I don't know what those levels mean. I guess if you do take the plunge and order antibody levels to COVID by talking to your provider, if you have undetectable antibodies, that's disheartening. It's not perfect, but disheartening. But detectable antibodies, I would have a very hard time distinguishing between what the level means or how long those antibodies will last. It doesn't tell you anything about memory. So I guess my very long-winded point is there are tests that can measure your antibodies. Right now, they're available. You can get them, but they're hard to interpret, and I wouldn't put too much stock in them at this point. But that will certainly become a thing, I think, going forward.
Great, thank you for the clarification there. I think we have time for one more question. It comes from Ragava, who says, how can we enhance T-cell response to COVID-19 in patients with malignancies and autoimmune diseases?
Yeah, so I think malignancies and autoimmune diseases have their own inherent endogenous effects on T-cell immunity. You can't do anything. I guess treating the malignancy may help. So there's actually studies for CLL, individuals who are treated with ibrutinib, which is actually a chemotherapeutic agent. It actually improves T-cell immunity by treating the cancer. So that, treating the underlying condition, if you have horrible lupus or something, treating it will help. And then certainly minimizing immunosuppressive regimens, which isn't always a choice. You can't take people with organ transplant off of their anti-T-cell therapies because T-cells are involved with organ rejection. So it's treating underlying conditions, minimizing immunosuppressive regimens that you can get away without. But at the end of the day, we're often stuck. And there's, I wish there was vitamins or something we can take for immune boosting, but I don't know of any science that exists. So again, you vaccinate because it's not binary. It doesn't mean you'll respond or you won't. You'll hopefully respond to some degree, maybe suboptimally. And now we do have these other therapeutic protections. Evusheld is the biggest one. And any patient who's on chronic immunosuppression would benefit from Evusheld.
Great, that's very helpful. Now we do have one final question that I want to allot some time to, even if it pushes us just a minute or two past. It comes from a patient who has primary autoimmune conditions. She's asking if COVID could potentially trigger secondary autoimmune conditions.
So that's a very good question and a hard one to answer. So any stressors on the human body, and I'm not just talking about stressors like fighting with your significant other, but viral stressors, pregnancy, illnesses, can trigger inflammatory responses in the body. This group is probably familiar with hives and urticaria. The number one cause of people experiencing hives is not a food allergy or an environmental allergy or a detergent. It's actually a viral trigger, a viral stressor, post-viral urticaria, post-viral hives. So of course, COVID-19 is a viral infection and it triggers, we've talked about it, an inflammatory response. So can it exacerbate underlying conditions? I would say yes. Has that been my experience? Have I seen a lot of individuals with chronic inflammatory conditions worse after COVID infection? Not a lot. That's anecdotal, Tonya. I'm sorry to be non-scientific, but I'm not seeing that a lot. So I think in theory, it's certainly a possibility, but it's not something I'm seeing in my clinical practice a lot. But certainly, again, if you worry about that or anything, reach out to your provider.
Yeah, I agree, Dr. Mustafa. We're seeing that same anecdotal, but we don't have good data. And I think this speaks to the importance of that personal relationship with your provider, having those ongoing discussions and expressing those concerns, but also the need for more science. We still have so much to learn. And 2 years in, again, I'm just continuously amazed at the new learnings and the way that the science is evolving here. So thank you for bringing us up to speed today, Dr. Mustafa. It was fantastic. I also want to thank each of you for listening today. Allergy and Asthma Network is and certainly is going to remain committed to bringing you the information that you need during this pandemic. Our next webinar is actually part of our Advances in Allergy and Asthma series. It will be presented on Thursday, January 27th at a new time, 7 p.m. Eastern. Alan Meadows will lead us through a discussion on digital tools for monitoring asthma. Again, I want to thank each of you for joining us today, for continuing to support this series and the work that Allergy and Asthma Network is doing. This is Tonya Winders on behalf of the staff and team at Allergy and Asthma Network, thanking Dr. Mustafa, and asking that we continue to work together to address all patients' needs in the midst of the COVID-19 pandemic so that we can continue to breathe better together. Thank you and have a great day.